This is a Stress George right here, and today we're going to be talking about the shortness of breath protocol. For me, one of the main things and one of the most important things to start when you're running any type of respiratory call is to have a baseline pulse ox. So that way you can have something to go off from and see if your treatment is improving the patient. Another thing that you're gonna be doing is you're gonna be gathering vital signs. You're gonna be gathering the respiration rate, rhythm and quality, lung sounds are very important as well. All of this is gonna help you determine and identify the severity of the call. And after that, one of the main things that you want to do is to start oxygen therapy. Put them on oxygen on a non-rebreather while you do everything else, 4 lead, 12 lead, and gather more information. Another vital signs that we already talked in class that is paramount to record is an entitled CO2, which is monitoring partial pressure of carbon dioxide at the end of respirations. And this is paramount because it gives you a live feedback of ventilations as it's happening. It helps you identify when somebody is not breathing, when you're having hypoventilation. As soon as it's happening, that's something that you're not gonna be able to notice if you're just monitoring the SpO2, because it's gonna take a little while for you to notice those SATs to start dropping. There's three main respiratory calls that we run. The first one is asthma. During an asthma attack, patient's airway becomes inflamed and there's extra fluid production of mucus. And the severity ranges on an asthma attack, and that's what's gonna determine how much of the protocol we're gonna be used. Normally, we will be starting with albuterol and with the Atrovent. We're gonna nebulize that at 6 to 8 liters per minute. And albuterol is a bronchodilator. Is a bronchial smooth muscle relaxant, and Atrovent is also a bronchial smooth muscle relaxant, but the mechanism is different. It does that by inhibiting acetylcholine receptors. And according to our protocol, which is no longer says that in there, it said that it also dried secretions in the respiratory tract. If that doesn't work, you will be going down to the CPAP, which is CPAP stands for continuous positive airway pressure. And what that does, it maintains PEEP, which is positive and expiratory pressure, which helps keep that alveolar opening, increasing that surface area, which improves oxygenation, and it also decreases the collapse of the alveoli, which is called atelectasis. I just wanted to say that word. Depending on the nature of the call, you're gonna increase or decrease the PEEP. We already talked about that. If it's an asthma, you're gonna go 5 to 7.5. If it's a CHF, you're gonna go 7.5 to 10. Another thing that we could use is epi. Epi IM 0.3 milligrams if the patient is not responding to treatment. And epi, among many things, is a bronchodilator and it's fast acting, so you're gonna notice the effects real quick. Another medication in our toolbox is Solumedrol. Solumedrol is an adrenal corticosteroid. It's an anti-inflammatory. It's long acting, so you really won't be seeing the effects of the medicine during the call. That's more for the stay at the hospital a few hours in, is when they're gonna really improve, and the hospital is gonna notice that we gave Solumedrol. Another medication that we can use is max sulfate. Max sulfate is a smooth muscle relaxant. Bronchiols are smooth muscle relaxants. Therefore, max sulfate works for asthma and respiratory emergency. One of the other common calls that we run are the COPDs. COPD stands for chronic obstructive pulmonary disease, which is a group of lung diseases that affect airflow to the lungs, causing shortness of breath. The main ones that we have is emphysema and chronic bronchitis. And this protocol is the same as the asthma. The only thing that's gonna vary is the epi, and we're not gonna be giving that. Lastly, we're gonna be talking about CHF. CHF stands for congestive heart failure, and it's a pump problem. The heart is not able to pump appropriately, causing fluid retention in the lungs and to the lower extremities, to the abdomen, which is ascites, to the liver. And a quick note: the way I remember is that if the left side of the heart was malfunctioning, you have left side heart failure. Where does it back up? If you think about cardiology and how the heart work, it's gonna back up in the lungs. And on the right side, if you're having right side heart failure, all that fluid retention is gonna go back to the peripheral circulation, your legs. And the treatment, well, we talked about nitro. We're going to give 0.8 of nitro, and nitro is a wonder drug. Nitro is a vasodilator. It decreases preload and afterload, which helps the malfunctioning pump take a break, the heart. It also reduces systemic and pulmonary resistance and lowers the blood pressure. All those things that are happening during a CHF exacerbation, nitro takes care of that. And by adding the CPAP, you add that CPAP, and that oxygenation is going to help clear the lungs, and it's going to help with oxygenation. And also, a bonus of CPAP is that it lowers the blood pressure. And things to remember when we're talking about all these protocols with COVID. You want to make sure that you're not aerolizing any procedures inside the ambulance. If patients have inhalers, we'll take them with us, and we're gonna give 4 to 8 pumps every 20 minutes, and you take it with you to the ER. The Solumedro is only for physician's orders if you think COVID is suspected, and there's limitations of EMTs, non-transport medic, transport medic, on how much of this protocol we're gonna be able to utilize. And on the temporary protocol, you can use also Terbuline, which acts as a smooth muscle relaxant. With the epi, you could either use epi or adrenaline for the asthma protocol. And one last thing I wanted to touch is that you don't have to follow these protocols in a straight line. You can do things simultaneously, or you can altogether bypass them. Just because max sulfate is your last drug doesn't mean that you have to use it last, or that's the last tool in your toolbox. In many instances, I do the Combivent, I do the CPAP, and I go for the max sulfate. It all depends, but just know that you don't have to follow them in a straight line. Thank you very much. This is Stress George back, and now we're gonna be talking about croup, which is a upper airway infection in kids. In most cases, the treatment consists of supportive care, humidified air. It's normally very minor to moderate condition, but it could also be a real emergency. On the other hand, the real emergency would be epiglottitis. And how would we know the difference between them, George? I'm glad you asked. Croup will have a barking seal. A seal bark off. Although croup in most cases is minor, there are instances when it's life-threatening. Anytime you hear stridor, which is high-pitched sound indicating partial airway obstruction, it's going to be a bad day. And the treatment will consist of the nebulized oxygen and nebulized epi, 1 in 1,000, 2.5 mLs over 15 minutes. you're gonna want to keep them calm, not agitated. And also you can use Solimetro, 1 milligram per kilogram IVIM, over 2 minutes. And that would be it. Thanks for watching. Please like and subscribe.